Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is CMOS MD CEO, Dr. Joshua Liu. Today, we're joined by our special guest, Dr. Margaret Lozovatsky. Dr. Lozovatsky is the Chief Health Informatics Officer and Senior Vice President for Novant Health, where she is the executive physician leader with oversight of clinical informatics across the 15 hospital system with 750 plus clinics and physician centers. She oversees the creation of a strategic vision and leads the use of technology by clinicians to improve the quality of care, create a remarkable patient experience, and enhance provider efficiency and satisfaction. She also explores areas where digital solutions can be utilized to improve the patient experience and promote clinician wellness. Dr. Lozovatsky also serves as a pediatric hospitalist at Novant Health Presbyterian Medical Center in Charlotte. Dr. Lozovatsky, Margaret, welcome to the show.
Hello, thank you for having me.
Well, it's amazing having you on. Honestly, you've led such a fascinating career with what I would say is a rather serendipitous path that I can only assume is maybe from following your curiosities. Before med school and before your pediatric residency, you completed a comp sci degree. And I was curious, where did that passion come from? How did you get into computers in the first place?
So I was always one of those kids that really liked math. There's not a lot of us, but I really enjoyed it. And when I started college, I knew that I wanted to go to medical school. So I didn't change my mind. I didn't change my path, but I wanted to get a background in something that was different than the subjects I knew I'd focus the rest of my life on. And so that's how computer science happened. I really enjoyed my time at Marquette University, where I had the opportunity to take a lot of the math and computer science classes.
Yeah, that's awesome. It's funny because you knew you were headed for medicine, but in a way you found your way back to the computing world. Following your degree, I think you went into bioinformatics pretty early on. What spurred that interest?
Yeah, I ended up graduating college early, and so I had a little bit of time. And one of my favorite professors at the time said, since you're going to medical school, why don't you take a look at this program? They had just started it. It was such a new field at the time. And so that's how I ended up taking a lot of the master's classes in bioinformatics, is because I already knew that it would be useful to me in my medical career.
I see. I wondered if it was because I think Marquette is in around Madison, Wisconsin. And so I was wondering, Epic was kind of coming up at that time and they were over in Madison as well. Did that have any influence on you?
So that's a really good question. And I do get asked that a lot because I happen to have grown up in Wisconsin. Honestly, not at that time. However, when I was in medical school, our system at the time was looking to implement Epic. So I was introduced to Epic very early because they were very much in our backyard.
Very cool. Yeah. So then you did decide to get your MD ultimately, and you started your career in pediatrics. But then how did you find your way back into technology?
That's a great question. I like to say that it found me, to be very honest. That's really how it all worked out. So as I mentioned, in medical school, they were implementing electronic medical records, and the same thing happened in residency. So I started my residency at a paper, and throughout that time, we implemented the electronic medical record. Interestingly, at that time, one floor at a time. So it was not done the way it is today. And very quickly, I found myself as the go-to person because I understood how to talk to the technology teams. So as problems were coming up, people would say, well, let's ask her, she'll know how to explain it so they can fix our issues. And that's how this all started.
Before we get more into tech, I'm curious, why you ended up in pediatrics. Was there something you knew you always wanted to do? Was that a last minute decision?
I have always known I wanted to go into pediatrics. And I joke a lot about the fact that when we started medical school, you probably know this, you would point at different people and say what they're going to do because you could just tell based on their personality. No one ever had any doubt that I would be a pediatrician. Like I would walk into a room and all the kids would end up on my lap. They still do today.
That's fun. That's awesome. Pediatrics is also kind of unique too, where I think you have such a wide range of patients from newborns all the way to adults. And so a lot of variability in technology access. And then I guess the younger you are, the more likely it's a parent you might be hoping would engage with you from a technology point of view. I think you and I talked about this maybe last fall at Chime, but it may refresh my memory. Like, how do you think about technology when it comes to pediatrics, knowing that it's such a different situation depending on the age?
Yeah, there's a lot of complexity, just like you said. both from a medical perspective, so thinking about all the tools that pediatricians need within their tool set, if you will, taking care of newborns to taking care of adolescents, they're all very, very different. But also, just like you pointed out, looking at the relationship with the patient, at some point it's a relationship exclusively with the parent, and then it completely shifts. There's a lot of complexity. What adds to that complexity is the fact that many pediatric centers are standalone. And so there's all of these challenges that happen at the time of transition when the child becomes an adult. And then very different challenges in pediatric centers that are part of a larger system, and thinking about how to create those tools that are unique for that adolescent population or the newborn population and not impact all of the other things that are in the system. So, yeah, there's a lot of work that goes into it, and we are nowhere near perfecting those tools.
Right. And sorry, just a random follow-up. When you think about like things like the patient portal, I mean, I can only imagine when someone is born, I guess the parent, let's call it, manages the account at some point. Maybe it transitions to a partnership as a child grows up, and at some point it becomes fully like the kids or now maybe at some point the adult's account. Is there some sort of guideline that you use to kind of transition that ownership of the account, or is it a bit more flex depending on each patient?
There are a lot of guidelines and actually a lot of laws that protect adolescent confidentiality. What's really interesting about that, as the Cures Act came to be, some of those laws directly conflict with the adolescent confidentiality laws. And so systems were put in a position where they had to make choices and problem solve a little bit on their own to ensure that we are keeping with the spirit of the guidelines and the laws, that we're protecting our patients in an appropriate manner, and we're being transparent with the information that both the patient needs and the parent needs. And it is really complicated. As you think about that record from the newborn stage, we haven't really gotten to a place where the adults today have had newborn records, right, in the computerized systems. But we're going to get there very soon. And then you start to consider, for example, a newborn child may have maternal information in their record. And then they become an adult, and all of a sudden they're seeing their mom's private health information. So those levels of complexity only get more and more challenging as we could continue to evolve how we provide access to whom and how we put appropriate boundaries in place.
That's so fascinating.
That is. So Margaret, after implementing the EHR, transitioning from paper, I think you were with North Shore at the time doing the pediatrics, you decided to, get out of the cold weather. You headed over for California with Cedars-Sinai for a few years to help with their information systems. And then you transitioned over to BJC for a number of years up until recently in 2021, at which point you took on this new opportunity with Novant Health. Given your experience over all of these large systems with different EMRs and different EMR optimizations, I'm really curious to understand, what commonalities have you seen across the board regarding like implementing any type of technology solutions? And then maybe what are one or two kind of strategies you've picked up along the way to obtain buy-in from a group? Because we all know it's a group decision, it's a group change management requirement for any change.
Well, one strategy that I picked up a long time ago is never to tell people that they're just like all the others, because no one wants to hear that. The reality is that, of course, every health system is a little bit different, right? But at the end of the day, there are a lot of commonalities. The bottom line is that all clinicians are driven by providing quality and safe patient care. And so to me, when I think about strategies of how to ensure that we have a good relationship with the clinicians and that we're able to help them, that's the strategy, is to tie it back to the patient. That's what we're all in it for, is to ensure that our patients are getting what they need. I think that, like I said, there are unique aspects of every health system. However, one of the sort of connecting factors across the board is that technology is still fairly new in the healthcare space. And it's a difficult transition. We talk a lot about the fact that some of those technological solutions may not come out of the box being ideal for the clinical spaces. So there's just this never-ending need to optimize and to continue to evolve. And clinical informatics is that liaison between the clinicians and the technology teams. And so we can really help be the driver of ensuring that that technology is what the clinicians need to ultimately take care of their patients. And with all of the challenges that we have seen in the healthcare spaces, this is one of those areas that has become more and more important because clinicians have so much stress put on them, especially in the last few years. So we can really ensure that we're taking some of those burdens away from them and making sure that the technology is there to help them rather than a barrier to get through their day.
On that note, I'm curious, like, are you finding that, like, when clinicians are considering new jobs and opportunities, are they asking more frequently about the quality of the EHR implementation, the workflows and the technology expectations as a way to help decide, hey, is this going to be a better staff experience for me? Are you hearing that much lately?
That's a really good question. I do hear that more than I ever did before. I don't think that even crossed people's minds 10 years ago, right? But today, people definitely ask, what EHR do you use? There are definitely some preferences, right? They ask their colleagues what the build is like. They ask about tools that are particular to their specialty. There are folks that have worked in systems that have very, very specific tools for whatever their area is. And sometimes it's hard to transition to something that may not have the level of complexity that you're used to. And so I definitely think that it's going to continue to become even more of a consideration as electronic medical records evolve.
Yeah, it makes a lot of sense. Margaret, I wanted to bring something else up. This was from another podcast that you were on. It's regarding EHRs. I just thought this was the most brilliant insight. You were basically alluding to the idea that when the EMRs were first implemented, we were transitioning from paper charting, and we basically took exactly the structure of how we used to do paper charting and put that electronically, which, as we know today, is not the way that we should think about, an innovation like an EMR or how technology can change what we're doing today. And it really led to a lot of these issues around discrete documentation, structured and unstructured data. And I think the metaphor you had was it's like taking your iPhone today and putting a computer desktop on that, and you're navigating on your phone in a completely different way than you would use a computer. So I thought that was just absolutely brilliant. And we all know this has contributed to a whole host of different problems like physician pajama time, documentation. I'm really curious to get your thoughts. How are you thinking about solving some of these more foundational EMR related issues?
That's a great question. I wish I had the magic solution. I don't know that there is one. I'll share a couple thoughts on that. To me, what we have created is unfortunately this challenging long-term problem, right? That we now, you sort of have to unwind and take a step back and say, what can we do now? Because this is the habits that people have created for the last however many years. One thing that is really important in my mind, which is simple, is education. The tools have evolved, right? That EMR build that was there 10 years ago is different than it is today, and yet the habits have not changed. And so part of it is really taking a step back and thinking about what is the purpose of clinical documentation. And to me, on paper, there were multiple reasons to put things into a note, one of which was to review information, because it was the one place you compiled things. Whereas in the EHR, that's not how it works. In the EHR, really the purpose of a note is to communicate. And there's, of course, all of these regulatory and billing requirements and all of these things that can be met outside of the documentation tools in a large majority of cases. So retraining folks to look at the EHR differently than they did their paper record. I always use the analogy of a filing cabinet. There are appropriate places to put things in the EHR, right? History goes in the history section and the medications go in the medication section. But I'm not sure that people were taught that way from the beginning. So that to me is the first step into correcting some of the mess, if you will, that was created years ago by people transitioning straight from paper to the EHR without taking the time to understand the differences.
Makes a lot of sense. It's almost like you need to get Yeah, everybody needs to go get their comp sci degree and understand a little bit more about computers and how databases work and all that. I mean, obviously, nobody has the time to do that, but I understand the point of education and how that could help there. Sorry, Josh, I think you had a question.
Yeah, you talked earlier about kind of like change management required for some of these transformative things with digital and healthcare. And I know that for you, you have a strong passion for culture and how building a great culture is critical for digital transformation. You presented about this at the Chime Fall Forum last year. And one of the things I remember you saying was that it can be hard given that cultures can vary between clinicians, IT folks, administrators, especially in a system as large as a Novant or a BJC and so forth. So I'm curious, like from everything that you've learned and experienced, what are one or two key pieces of advice you would give to other digital health leaders on how you can build a better culture for healthcare innovation?
I think starting with curiosity is really the first step. We get so caught up in what we know. And it's so important a lot of times to take a step back and ask questions. And a lot of times there's really interesting tech. And so in my role, as you could imagine, I get contacted by a new company 20 times a day that is really excited about their solution. And it's easy to often get caught up in the next new shiny thing. It's hard to take a step back and say, what is the problem we're trying to solve? So to me, as I look at a lot of these really complicated issues in healthcare, it's important to simplify it, to boil it down to what are the issues that we're trying to address and how do we find the solution to those issues? And they don't always have to be super complicated solutions. Sometimes it's, again, about education. It's about rethinking the way that we approach our processes, our day-to-day work. And to me, that's innovation in itself. So to answer the question of what are one or two things that I've learned is that sometimes the answer is simple and right in front of you. And if you ask enough questions, you will find it. And always go back to the problem that you're trying to solve.
I love that.
Yeah, and I was going to say, like, I think your comment about sometimes the best innovations are simple and right in front of you reminds me that, like, I think for a long time now, people hear innovation in healthcare and they keep assuming tech and tech and tech. And I would always tell people, like one of the best innovations that actually got scale, like, many, many years ago was like the APGAR score, right? After a baby is born, it's like, there's no tech there. It's just a simple, brilliant score used to measure, the health of a newborn right away. And it's spread like wildfire globally. That's an amazing innovation. It has nothing to do with technology. Technology maybe can like enhance how we document and score and all that, but some of the best innovations are not tech at all. Now, as a CHIO, maybe you have to do more tech, but I'm sure you're doing a lot of non-tech innovations too.
Yeah. And don't get me wrong, tech is important. I feel like we have come a long way in the technology solutions that we have in place. And absolutely, I always want to hear about the new innovative technologies that are out there. But I think it's important to connect it back to the clinical spaces. And what do those clinicians need to be able to provide care to our patients? And if we don't connect it back to that, then we're putting solutions and creating problems instead of solving problems.
Yeah.
Oh, sorry, Alan.
I was just going to say that's a great framework for understanding, tying it all back to the problems, not creating problems through a solution. Makes a lot of sense.
Yeah, and I was wondering, do you think, like, Margaret, one of the challenges is that I'm not saying this never works, but because there's a lot of, frustration with healthcare from the patient side of things, often there are folks who don't have that clinical background who try to use tech as the solution to solve all these problems in healthcare. But then when you're in the healthcare system, you actually realize and you have the context that a lot of these problems are not solved by tech or due to tech. It's change management, it's incentive misalignment, it's all these other things that have nothing to do with tech. And so for a lot of folks who try to just throw tech onto healthcare and think that's going to solve the problem, they get surprised that that's not the case. Do you think that might be part of the challenge sometimes?
Oh, absolutely. I think that it's important to have a good partnership with people that are coming from outside of healthcare that have seen other industries, and they have really, really important insights that they bring to the table. But that partnership with the people that are in the trenches is really important, because I think that the complexity of the day-to-day in healthcare is something that, if you have not had experience with it, is difficult to understand overnight. It's something you really need to learn. And I appreciate, I work with a lot of people who are from outside of healthcare. I appreciate the ones that really do ask a lot of questions and want to learn and understand and get at the problems that we're trying to solve, instead of taking the insights that they have in another industry and trying to apply them to healthcare, because that often does not work.
Mm-hmm. Yeah. Margaret, going back a little bit to what you were saying around centering around the problem and really figuring that out, during the Chime Fall Forum last year, you tweeted, "Don't focus on solving all virtual care problems at the same time. Understand the challenges and tackle them one at a time." I'm really curious, what sort of framework or system do you use to prioritize all these different problems? Because it's not always just one problem that, exists.
That is always the question of the day, right? We talk a lot about governance and prioritization, and there is absolutely more problems than there's ever going to be time to solve them in healthcare and in any industry, in any job, right? We call it job security, as I like to say. I would say that the way that I like to prioritize these types of issues is to go back to the people in those spaces. And so, to me, the most effective type of governance involves the end users and the leaders in those spaces. So understanding what their priorities are is what allows us to prioritize the technology solutions. A lot of times, again, we see a product and we say, oh, this would be cool, this will be great. But if you ask the people that are running their clinics and running the hospitals, and the physicians and the nurses and the APPs that are out there practicing medicine, they're going to tell you that their priorities are directly linked to their problems. And so, to me, it always goes back to, what are the challenges that they're seeing and what do they think are the priorities?
Okay.
So we have spent a lot of time at Novant building out governance structures that really directly engage the people that are in charge of those areas and the people that are at the bedside. And I think that that will allow us to be a lot more nimble in getting to the real issues.
Yeah. Well, speaking of being nimble, right at the beginning of the pandemic, I know that Novant Health was able to set up telemedicine like rapidly. I think it was under 48 hours. And I'm curious, what foundational elements were in place to make that endeavor possible?
Yeah, Novant did a phenomenal job in turning on their telemedicine platform. And I will share, I was not at Novant at that time. I joined in 2021, but have had a lot of conversations with folks that were here. And I think it's a really good question. Why were they able to do that? Novant was always very forward-thinking and continues to be forward-thinking. And so the recognition that telemedicine is part of the future was always there. And the fact that we're going to need to have alternative ways for patients to see their physicians and APPs allowed them to put all of that infrastructure in place. What I think is interesting, and probably not unique to Novant, is that patients weren't necessarily interested in this at the time, and neither were the physicians. There was a lot of conversation about the fact that I'm scared to do this because I may not be able to do a full physical exam, and how am I supposed to evaluate the patient? And so even though all of the technology was in place, it goes back to the fact that technology does not always solve the issue, right? There just was not buy-in from either side of the equation. And when the pandemic hit, because the technology was already in place, and kudos to Novant for having all of that there, turning it on was incredibly quick. And of course, you had the buy-in because we had a reason to do this. So it really did take less than 48 hours for them to get all of the clinics up and running. It's amazing.
Yeah. Sorry, Josh, I saw you had something.
Oh, I was just gonna say, we're now, I guess, 3 years since the pandemic, and so there's been a lot of experience now with telehealth and for many organizations. really telehealth on en masse for the first time. And so I think we've seen from the data that there are certain specialties where telehealth has been sustained, like let's say behavioral health, for example. There are others where it's kind of maybe reverted back to a mean and is a lot lower in use than it was at the start of the pandemic. Do you feel that we've kind of reached that new steady state at this point? And it just turns out there are some specialties where telehealth makes more sense and others where it makes less sense? Or do you feel like there's still like a curve that we're going to go upwards on in the coming years because of other drivers? I'd love to get a sense of like where you think we're at today and where we might be heading.
Yeah, that's a great question. And something all healthcare systems noticed, right? As people started going back into the office, the numbers just went way down. And there are a lot of people asking that question. In my personal opinion, I would say that we have reached the steady state for now. What I envision is that we will continue to progress in this space. There's lots of discussion about initiatives like hospital at home. And so I do think that we're going to continue to push the envelope in allowing care to happen in locations that are not the brick and mortar traditional hospital versus clinic setting. And what I would predict is that the change management required for that is just going to be much, much more extensive than what happened during the pandemic because people had the incentives. So just like you said, lining up those incentives is going to be really important as some of these projects are stood up for hospital at home. I think there's a lot of opportunity in the emergency department, urgent care space to be able to do some of that virtually. But I just don't think it's going to move nearly as quickly as it did in 2020.
Can I ask you, like, when you start to roll out these like very innovative new models like hospital at home, and in some ways you're often asking people to volunteer to try something new that some people might say, well, I never signed up to do this when I joined healthcare. Is it hard? Like, are you just like looking for people to raise their hand and you're finding those champions, or is there something unique about the culture that everyone's just on board when you try something new? I'm just curious how you go and get people rallied to do something new like that hospital at home initiative.
It's a little bit of both. I mean, you definitely need those champions, those people that are always forward thinking and that are going to try the new things. But you're absolutely right. There are people that we're going to be dragging, kicking and screaming to do some of these new initiatives. And to me, when I think about the change management process, you've won when you get those people on board, right? And it's really important as we're doing this to not just get champions, because those are people that are going to try new things no matter what is introduced. But it's to really understand why some of the folks that are hesitant are not wanting to do it and to come up with a system that they're able to buy into. To me, once you do that, then you've sort of gotten over that hump of the new changes that you're putting in place.
Does that mean that as part of your role at CHIO, you're constantly, I guess, going around the system and communicating with people and explaining why you're doing these disruptive digital things and aligning on the problem, and so it's not so much technology that you're doing day to day as it is communication and change management at this point?
Oh, absolutely. Absolutely. So much of my job is the interactions with people, right? And like you said, the communication piece of it is so important. I have always said that doctors are very logical people. Not that doesn't apply to everyone, but I think it holds true for the most part. And to me, what's been the most effective is just being very transparent and honest. I think that people appreciate the transparency. They appreciate when you share with them why we're doing things, what some of the barriers might be, what some of the things that they're going to experience that are not going to go well, right? No one ever tells you what's going to be painful to experience and what is going to add to your day. But I try to be very thoughtful about ensuring that we communicate those things, because I think that folks have so much fear, right, of change. And if you try to, from the start, share with them the things that you know are going to create problems for them, then they're much more willing to try new things.
Makes a lot of sense. Yeah, sort of like that fear setting approach, understanding what the downside risks could be, and how their practice could not change without the implementation. I'm curious, and Margaret, half kidding, but when you suggested that some of those people that are maybe dragging their feet through the mud and they don't want to necessarily get on board with the change, is that how you're actually structuring some of your KPIs when you're implementing a new technology? Is did we get Dr. So-and-so on board? And if so, we check that off.
Yeah. We don't go as far as naming names.
Yeah.
However, I do like to include physicians that I know are resistant to change in a lot of the governance bodies.
Yeah.
I think that they're really an important voice, as painful as it may be sometimes. And I'm always grateful when I get feedback. We've had, like in any system, right, new technology rolled out regularly. And sometimes it goes really well, and sometimes it just doesn't. And sometimes there are challenges that are significant. And when people send me messages about how something is not working, I'm always very intentional about thanking them, right? Even the ones that will be sending them hourly. I think it's important for them to understand that we're hearing it and we're going to address their needs as quickly as possible. And it's also important to be honest, to say, oh, well, I can't fix that, or I can't fix that in the next month, but we will get to it. So that's always been my approach. Those physicians and other clinical specialties that are the most resistant are the ones I want to be in closest contact.
I think that's really smart too, because if you involve the skeptics so closely, and at some point the skeptics become ambassadors because you've overcome all of their challenges, people will believe them. They're like, oh, wow, like so-and-so is the biggest skeptic of technology ever, but they're actually using this and championing it. Okay, like this thing actually must work. It can be a pretty powerful thing when that happens.
Oh, absolutely. And especially with any new implementation, it's so important to get them on board, right? Because like you said, they will be your biggest champions.
Definitely. So Margaret, I was curious, today there is this explosion of patient-facing innovations, like everything from chatbots and digital care journeys and RPM. I'm curious, what are you most excited about today?
What I am most excited about is getting to a place, and I don't think we're there yet, but I think we're close, where the patient can get what they need in their own way. And so, like you said, there's all these options, right? What we haven't gotten to is recognizing that every patient is unique. While I may want to schedule my appointment on my phone, my grandmother, for example, may not want to do that. She may want to call the office. And my kids, as they get to a place where they're able to schedule things themselves, they are going to be all about the chatbot, right? And Snapchat and whatever new innovation is going to come into healthcare. But what's important is to recognize that it's not a one size fits all, and to evolve our approach to allow patients to interact with the healthcare system in a way that makes sense for them, and also in a way where we will continue to provide safe and quality care. So I think that's an important piece of it too, is to have those touch points that they can select and to ensure that they're able to get to the right place so that we're triaging them appropriately and things don't fall through the crack.
Right. I think that's so fascinating. In the same way that we often think about how clinical interventions need to be personalized to the patient, you're kind of touching on this idea of, well, access in many ways should be personalized to the patient and the way in which they want to be reached, or in the way they want to access healthcare, which I guess until recently hasn't really been part of the personalized part of healthcare. That's really fascinating.
Yeah, that's a good point. That's another important aspect that we need to get to, right? Is to have this whole concept of precision medicine that we've been talking about for as long as I've been in this field, to get to a place where we truly are able to provide care in a personalized manner. So the whole process needs to get to a precise way of approaching our patient.
I love that. So Margaret, just being mindful of your time, let's flip over to what we call the Fast 5 lightning round. This is just 5 questions to get to know you better. The first question we have is, what is your favorite book or book you've gifted the most?
So I love to read lots of books that I love. The one that I would say is my favorite is How to Win Friends and Influence People by Dale Carnegie. Great book. It was introduced to me by my husband, and we have gifted it to lots of people.
And it's probably super useful for your day-to-day work with the truly. I mean, a lot of it comes down to influence and persuasion in getting folks on board with different ideas. So I love that. Question 2, who is a person either dead or alive who you'd love to meet?
I would love to have had the opportunity to have met Golda Meir. She is such a fascinating character. Interestingly, she was born in Ukraine and I was born in Belarus. Family migrated to Milwaukee, as did mine. And she went on to do amazing things. But the reason, outside of the fact that we have such similar backgrounds, that I would love to meet her is that she's a person that I think about that really stood up for what she believed in very, very difficult political situations. So I really like that.
Oh, that's awesome. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
Hands down, the ability to read people's minds. In my line of work, that would be very useful.
Right. I get that. That's good. We do have a follow-up on that. What if you couldn't turn it off?
It would get very loud.
Yeah, you're constantly just... You're okay with it, though.
I am. I think it would be such a useful skill to have.
Yeah, it would. Awesome. Question 4, what is something in healthcare you believe that others might find insane?
I don't think that the average patient realizes the amount of things that a physician is balancing in a day. And that includes all specialties, all settings, ambulatory, inpatient. And so I think that that cognitive burden that's put on our physicians is something that most people just don't realize, as the physician's going from room to room, trying to manage all of their patients and all of the emails and phone calls and not missing any details. It's really something I wish that more people understood and had insight into.
Yeah, definitely. Last question that we have, if you could travel back in time to any event or moment, what would it be and why?
I think you could read that question in multiple ways. And the way that I looked at it is any moment in time in my own life. And what I would love to do is go back and watch some moments in my childhood as an adult. I feel like a lot of times you miss the context of what's happening because you're a small child. And you also miss a lot of the valuable insights that your parents, grandparents are trying to communicate to you. So I would love to have the opportunity to hear that all again as an adult and be able to reflect on it differently.
I love that. That's such an insightful answer. Well, Margaret, thank you very much for spending some time with us today. Really appreciate having you on the show. You can find Dr. Margaret Lozovatsky on Twitter at Dr. Lozo, I believe. And that's a wrap for this episode of The Digital Patient, hosted by Seamless MD. You can follow us on Twitter at Seamless MD. And if you like the podcast and you want to learn more, visit www.seamless.md. Margaret, again, thank you so much for spending some time with us and sharing some wisdom.
Thank you for having me.